Hello and welcome to today's online laser course about CSCR treatments with a particular focus on the navigated subthreshold laser. My name is Ulrike Rahn and I am the clinical manager at ODS. I'm delighted to have today Dr. Chhablani online with us. He is an expert in CSCR as well as subthreshold lasers. Hello, Dr. Chhablani.
Hi everyone. Thanks for the invitation. I'm looking forward to this exciting webinar.
This time we also have online Stefanie Gerke with us. She is the VP Sales and Marketing of ODS, and she's joining us today and helping us with all technical setups because today I'm very happy about a kind of different webinar. I hope you are going to enjoy that, especially after a full year of missing live events and all listen-only webinars. We thought of trying some more interactive formats and implemented several interactive elements in today's webinar. As in standard webinars, you can just enjoy listening the presentation and ask questions via the chat window at any time. One further interaction element will be that we today use a survey presented by menti.com where you can vote together with us. The votings will be immediately shown. It doesn't require registration. It's completely anonymous. We would be happy if you all participate in that survey. To participate, open your browser, or the best would be on a smartphone or any other mobile device. Go to www.menti.com and enter the code you will see as soon as the first survey question is coming up. Again, there's no need to register nor to consent to anything. It's just voting, and we will not be able to see who responded what, and the answers will not be saved. The last option, and that's, I think, one of the most advanced in participation options, we highly recommend to participate with the interactive planning part. Download the Navigate app on your iPad, if not yet done, and plan in parallel to Dr. Chhablani. If you experience any issues with that downloading, just drop us a short message. Stefanie is trying to help you with that. If we cannot help you immediately, you also have the chance to plan a long time after the webinar. So let's probably start with the first survey question. If you could open the website on www.menti.com and enter the code 51250456. You see that code also on the top of the presentation. Once you have entered the question, you will see the first question and you can participate in the voting. I see already the first votings coming up. We'll give them a short second to see, but I see the majority of our audience so far has experience with CSCR treatments. The voting closes in just a second. And here we are. More than half of the audience at least have some experience with CSCR treatments. The second question is, which type of CSCR treatment options are you actively using? You can select multiple aspects. That's a question mainly for those who have already experiences. That's nice. So a lot of people already have used threshold laser. That's still changing. We have a few seconds to go. And the voting is, yes, sorry, that was a little fast, but we could see it was relatively equally distributed over the technologies, with most of you knowing already some about oral medications. Then next question, please. This is the last for the intro. Thereafter, we start with the webinar. Just to have us knowing who already downloaded the Navigate, how many of you can participate interactively. So more, okay. As you can see, the majority does not yet have downloaded it. If you have time afterwards, you can also plan after the meeting, after the presentation, and now just listen and enjoy. But I'm happy that some people participated in the survey. I think let's then move to the topic of today's webinar. We will start with the theoretical part with the theoretical overview of treatment options for CSCR, followed by an interactive case session on how to use navigated subthreshold laser treatment. Now I would go ahead and switch off my webcam so that you can entirely focus on the webinar.
Hello, everyone. I'll be talking about central serous chorioretinopathy. We will be primarily focusing on subthreshold laser and treatment strategies. These are my financial disclosures. So agenda for today is we will be starting with introduction for CSCR, then we'll be talking about management, photodynamic therapy, threshold laser, subthreshold laser. Then we'll be talking a little bit about comparison between PDT and microsecond pulsing laser. And then we will have question and answers. And you already got the information for question and answers. Let's start with CSCR introduction. What is CSCR? It is a major cause of vision loss in middle-aged men. The incidence reported is 9.9 per 100,000 for men and 1.7 per 100,000 for women. It is primarily characterized by localized and limited serous detachment of neurosensory retina, which is involving the central part of the retina. This is why the patient primarily presents with distortion and blurring of central vision. Most of the times the CSR resolves spontaneously. However, we know that almost 10% of these cases tend to have recurrent cases or chronic cases. The visual impact of CSCR is often underestimated, and patients still suffer from visual dysfunction even after resolution of subretinal fluid. So what are the risk factors for CSCR? There have been a lot of research to understand the risk factor of CSCR, but the study from Louis et al. Clearly shows that the psychological stress, antacid or anti-reflexin agents, and pregnancy are one of the very common risk factors for CSCR. How do we classify CSCR? Traditionally, CSCR has been classified as acute or chronic, but the recent classification from Professor Cohen divided the CSCR into 5 categories: acute, persistent, recurrent, chronic, or inactive CSCR. Recently, we formed an international CSCR group which classified CSCR based on multimodal imaging, and we classified CSCR into 3 categories: simple, complex, and atypical. I'm not going into the details, but overall this classification uses the multimodal imaging and primarily based on total area of RP alteration, unlike the conventional classification, which is based on the duration of symptoms reported by the patient. How do we image and diagnose CSCR? As we all commonly perform an OCT scan in the clinic, which shows a subretinal fluid, as you can see on this scan. We perform fundus autofluorescence, which shows a hyper and hypo areas of RP alteration. Then, if needed, we do a fluorescein angiography, as you can see here, and ICG, which is one of the most important imaging modalities for CSCR, that shows a diffuse choroidal hyperfluorescence as seen in these pictures. So let's move on with our second component of today's agenda, which is a CSCR management overview, where we will be talking about the various options to manage CSCR. So as I said that we will still talk about CSCR in acute or chronic. Acute is which usually resolves. That's why we usually do not intervene at the presentation, but we tend to wait for 3 months. And if it does not resolve, then we take the second step. We call it as a persistent CSCR. So how do we actually manage persistent or chronic CSCR? There are various options, as you can see ranging from laser therapies to oral treatment and surgical or anti-VEGF. But for today's discussion, we are going to focus only on the laser treatments. And laser involves a threshold laser, which usually we do for extrafoveal leaks, subthreshold laser where we can actually treat the juxtafoveal or subfoveal areas, and PDT usually we tend to do when the patient is not responding to any of these other treatments, or if the patient has juxtafoveal leak in cases of acute CSCR, or I particularly prefer a PDT for a chronic CSCR. Let's move on to the component of photodynamic therapy, which where we are going to talk about how does it work, how do we perform, and what is the evidence for PDT. So how does PDT therapy works? PDT leads to the choriocapillaries hypoperfusion, and it eventually leads to choroidal vascular remodeling, and it leads to reduction in choroidal congestion, vascular hyperpermeability, which is the primary cause or a proposed cause for CSCR. This is how PDT works in CSCR. So this is a very interesting study from Professor Chan et al., which clearly shows that how does the choroidal congestion reduces. As you look at the top row, a red circle in the middle picture, which shows a dilation of the choroidal vessel, and the picture in the bottom row, which clearly shows the reduction in the diameter of the choroidal vessel. And they claimed that PDT leads to narrowing of the dilated and congested vessels. It leads to significant reduction in choroidal vessel diameter and eventually leads to reduced choroidal vascular hyperpermeability. And these changes in choroidal vessels were noted almost up to the 1 year of follow-up. So what is the evidence of PDT in CSCR? As you can see that there have been multiple retrospective, couple of prospective studies on PDT, which have showed a limited benefit. But yes, there is some improvement, but we are still unsure that what is the difference between in terms of outcome between half dose and half fluence for CSCR, which still needs to be evaluated further. Let's move on to the second segment of the management, which is a threshold laser application. So threshold laser, which we have been using for many years, it is a continuous wave application where you actually go ahead and find a visible endpoint, and the thermal energy is delivered and causing photocoagulation in that area, which probably leads to the closure of the lead, and it eventually leads to the reduction in subretinal fluid and stop the further leakage. However, we understand that such threshold or conventional or continuous wave laser cannot be performed in eyes where you have a juxtafoveal or a subfoveal leakage, or when you have a diffuse leakage such as a chronic CSCR. You really cannot go and do a threshold laser to large areas of RP alteration or RP diffuse epithelitis, which is called as, and do a threshold laser. For those eyes, you certainly require a different subthreshold or a PDT. So how does a subthreshold laser works? Where we really go ahead and look for the leakage area. The parameters we usually use is the 100 microns and 100 milliseconds. I usually start at a least power, which is like 50 millivolt, and you keep increasing the power till you get a faint whitening, or I should say just a grain, which is called as a threshold laser spot. This is a very nice video from Professor David Brown from Houston, where you can see that the Navilas laser is being performed, where he went ahead and did the laser planning in the first step. And this is this time where you can see that the contact lens is not placed on the eye. Patient is moving the eye, and with the help of eye tracking, you can go ahead and do the laser. This is another case where the planning is being done by importing the fluorescein pictures, and once the planning is complete, you go ahead and do the laser, and with the help of eye tracking, you can see that even if the patient is moving the eye, you are still able to deliver the laser energy to the pre-planned areas. So this is the benefit of Navilas laser, where you have a computer laser based planning and eye tracking, which helps to deliver the energy to the right spot, unlike the conventional way of doing the laser. Let's move on to the subthreshold laser component of today's presentation. So what is subthreshold laser? This is a very confusing term where people have been using various types of terminology: sublethal, subthermal, subvisible, non-damaging photocoagulation therapy, microsecond laser. But I'm just going to explain to you what is subthreshold laser. So subthreshold laser is primarily where you really do not cause any obvious damage to the retinal cells, where you can see that subthreshold laser could be of nanosecond pulsing as it is seen in SRT or 2RT laser. It could be an endpoint management, which is a part of Pascal laser. A subthreshold laser could be a microsecond pulsing laser, which could be either an infrared, which is a longer wavelength, or a yellow wavelength as well. So we are going to focus on the yellow wavelength while talking in this presentation. So what is the principle of a microsecond pulsing laser? It is primarily a chopped beam where you actually uh, cause a thermal activation, or I should say without causing an activation, thermal activation or heat shock protein without causing obvious photoreceptor destruction. That's why you are able to comfortably perform this laser to a juxtafoveal or a subfoveal laser or a diffuse leakage, which we experience in chronic CSCR cases. So what is the evidence for subthreshold laser? As you can see that these biochemical changes have been reported from these three publications, that these changes happen with the microsecond laser. I would say one of the most important is the HSP70, which is what primarily is responsible for the efficacy of the subthreshold laser. So this is the video showing how does the microsecond pulse laser is being done using Navilas system, where you can see that the planning is being done, and then you can use the same technique as we showed in the threshold laser. You can use the eye tracking and perform the microsecond pulse laser using Navilas. So what is the evidence for this 577 microsecond laser? There are multiple studies which have been done where they have shown a satisfactory outcome using this microsecond pulse laser. We will be talking more in detail in coming sections where we are comparing with PDT, where we'll be talking more about comparative trials. So the one of the most common question is asked while doing a subthreshold laser is that what are the parameters we are using? And there are like almost, we have reviewed 18 publications, and we found that the laser parameters are varying between the publications, and there is no standard protocol till now. However, we are right now trying to establish standardized protocol which we can actually uh, use worldwide. So, but for this talk, I would say the most frequently used parameters for using microsecond is 5% duty cycle with 200 millisecond duration, where you have the spot size of 100 to 200 microns. One of the common question is that how do you actually find, or how do you actually titrate the microsecond pulse laser? So I particularly start using the microsecond pulse laser and do the titration or finding the threshold using a microsecond pulse laser. And then I actually, once we have achieved the threshold by using the microsecond pulse laser, then I usually cut it short to 25 to 50% of that power. And that's the power you are going to use to treat your patient.
I'd like to interrupt the presentation for just a moment because I received already two questions that I found reasonable to ask right away. Dr. Chhablani, are you ready to take the first question? Yeah, I don't hear you. You still seem to be muted.
Yeah, sure.
Perfect. Now I also hear you. So you have been speaking about different laser technologies and parameters. Is there a difference between diode and microsecond pulsing laser with regards to the parameter setting?
That's a very interesting question, but unfortunately without any answer. Honestly, there is nothing, no studies which have been done comparing head-to-head the diode and the yellow laser. I do have some experience with both the lasers, more with the 577. I would say it's really clinically, as far as the publications and the literature supports, that some of the studies have shown that it actually has almost a similar protein expression. So theoretically, there should not be a problem, but I would be very careful in real life, in clinic, if I'm switching between the lasers, or even if I'm switching between the devices or using the same laser. Because as you know that we are yet to learn a lot about these lasers. So we know that the longer wavelength lasers such as 810 has a much wider therapeutic range, but I would still consider that be careful when you switch between the wavelengths, be careful when you're switching between the devices of the same wavelength. I hope this answers your question.
Definitely, I would say that gives a lot of details to also answer the second question, but I'm very happy that we have answered both questions. For those who joined late, because we have a few people in the audience who joined a little late, you can ask questions at any time via the question window. You find that in the webinar application under chat. Just type in your question, we will see it, and I will ask this question. Also, for those who joined late, and as a reminder for everyone else, at the end of this webinar, we also will have a repeated survey in the style of a multiple choice question. We invite everyone to join that on. Go to the browser, open www.menti.com, and then I will give you a code to participate in that survey. But now I suggest we continue with the presentation. If you'd like to participate in the planning phase, that's starting in the next moment. So if you have, for those who have downloaded the Navigate app, open it and select the case number 1 CSCR. That's the case Dr. Chhablani is presenting in the next minutes. So yeah, we continue. I hope you enjoy also the second part.
So let's move on with the case. This is a patient of mine which I saw in 2014. This is a 49-year-old male who presented with complaints of seeing a black spot right in the center in his left eye for the last 2 months. He did mention that he was diagnosed as CSCR, and then they did not offer him any treatment. Rather, they just told him that it should resolve on its own. So this was his right eye is 2020 and 6, left eye is 2025. You can see a faint subretinal fluid area in the right in the center, which is almost more than 1.5 to 2 this diameter area. This is a picture on OCT. Right eye is normal foveal contour. Left eye does have a subretinal fluid involving the fovea, and these are the fluorescein angiography pictures, and where you can see that there is a juxtafoveal or just a subfoveal laser, and this is what must be the reason that previous physicians were reluctant to treat this patient, considering the central or subfoveal location of the leak. So let's open the Navigate app and work together while planning this laser. I have imported here a fluorescein angiography image, which shows the leakage very clearly, very close to the fovea. Then you have this caution zone where you can actually put this area where you can have the caution zone, like I'm putting the fovea, and then you can have one more caution zone as the optic disc. But because we will be using the foveal area, so I'm just going to remove this. So we'll be using around 50 microns, because as I was telling that the leakage is very close to the fovea. So because as you can see that it's very difficult to do a single laser mark to this leakage. So I'm just going to use a multiple laser spots, and I have chosen spacing between the marks as 0. So now you are going to place multiple spots with 0 spacing right at the area where you want to do the laser. And there you go. And just to give you one more overview, now we have 50 microns spot size without any spacing. They are confluent burns. And now we are ready for the laser. Okay, so before we really end, I would again re-emphasize that I'm doing a subfoveal laser, which is 5% duty cycle with the confluent bonds. So before you really press the foot pedal, make sure that your duty cycle is at the lowest, that is 5%, because you understand that you are hitting the fovea with this laser. And this is the scan of the same patient 2 months after the laser, where you can see the visual acuity in the left eye has improved to 20/20 partial. The fluid has completely gone, and you can see that there are no signs of structural damage. Even when we perform the laser right in the center, we do not see any signs of structural damage where we perform the laser. So this patient came back after 2 years. So that means he was doing really well for 2 years, with complaints of a recurrence for last month or so, where I saw the fluid pocket again in the center, because we know that there was a subfoveal leak. So probably the leakage again started, and we went ahead and did the 5% laser to the same area, and the fluid resolved completely. So let's move on to the second case. This is a patient who presented to me with a diminution of vision in his both eyes for last 6 months. PDT was performed in 2016, and the right eye vision was 20/50, left eye was 20/60. These are the OCT scans, as you can appreciate very clearly, a pachychoroid with subretinal fluid and a shallow pigment detachment. And let's focus on one eye at a time. This is the right eye picture, the OCT which we just saw. This is the right eye fluorescein, where you can see the diffuse leakage. There are multiple hyperfluorescent spots, and you understand that this is falling in a category of a chronic CSCR. You can see that how the leakage is increasing uh, in the late phases. These are the ICG pictures clearly showing the hyperfluorescence and a diffuse leakage as well. So let's open the Navigate app, and we will go ahead and do the laser planning. As you can see on the left panel, there are caution zones. Let's start with that. Let's cover our fovea. This is good enough. And then one more caution zone on the disc, because we are going to come close to the peripapillary area. I understand that it is a microsecond laser, but we still should be taking extra precaution of these important areas. And now my fovea and optic disc are covered. Now I will pick up multiple spots planning, where I just do a long press. Because I'm going to use the 5% duty cycle, I will go ahead and choose confluence spots with 0 spacing, as you can see it here. And the laser spot size is 100, which is fine. And now I will start the planning, and let's do with our fingers just the planning. As you can see that I am doing much larger area, and you can comfortably do the confluent laser. As you can see, almost everything is covered. Because of 5% duty cycle, we are very comfortable doing more areas, and you can actually go all the way very close to the disc as well. And just to bring attention, that you can see that the areas which were much brighter, they are also covered with my confluent laser planning. I'll just go ahead and do a little bit here as well. So now you are seeing that we have planned the laser, but if you really want to do a little fine tuning, use the eraser click, and then now you can do some fine tuning and erase some of the laser spots which you are not comfortable with, like I'm doing right now. That's it. Now we are ready for the laser. Just to bring up the summary, this is a 5% duty cycle with 100 micron spot size as confluent laser planning. And now we are ready for the laser. Okay, so now after the laser, this patient comes back after 2 months, and you can see his visual acuity has improved to 20/40, and the fluid has significantly reduced in the right eye, and the PD has slightly increased, but this fluctuation is something which we notice in CSR patients, and then we decided to observe this case. So just to summarize, the subthreshold laser or a microsecond pulsing laser, it is primarily a chopped beam of the same laser, which is going to deliver a microsecond wavelets that heat up the retinal pigment epithelium. It uses a confluent grid and covers all leakage points of the perimeter's area. The common parameters are 100 microns and 100 millisecond for subfoveal and 200 millisecond for extrafoveal. I usually prefer a 5% duty cycle, and primarily we titrate or we find the threshold of the laser by using a microsecond pulse laser. And once you have the threshold, uh, you got the threshold, you cut it down to 25 to 50%. My preferred practice is cutting down to 30% and performing the laser. You do have recurrences, but you can confidently retreat this patient with the same laser, because as we have experienced that this subthreshold laser does not lead to any structural damage on available imaging modalities. So let's move on to something more interesting, which is a PDT versus microsecond pulsing laser. I'm just going to talk primarily about the comparison between these two treatment modalities. So there have been a couple of studies which clearly have shown a controversial studies. A place trial, which was a randomized study, favored PDT, but the real life studies have favored microsecond pulse laser, where just to show you that the place trial used primarily half dose PDT, but most of the real life studies have used half fluence PDT. Place trial performed a diode laser, but the real life studies used yellow laser. Place trial did exclude the subfoveal laser, which is not the real life situation. We tend to see these patients where you have leakage in the subfoveal area. Most of the studies have used non-navigated laser, but the study from our group did use a navigated microsecond laser. So just to summarize the benefit and the challenges between these two treatment modalities, PDT, we know that it is an expensive procedure, it is an invasive procedure, it does have side effects, and it it definitely comes down to the availability of PDT, as because we know that many of the countries do not have PDT available anymore. In contrary, the microsecond pulse laser uh, is is relatively cheap. It is repeatable. We know that it does not lead to any structural damage. However, it has its own challenges of because we really do not have a standard protocol so far. However, we do not have any complications, which is in favor of microsecond pulse laser, but it is yet to be evaluated much more by using more randomized control trials. So just to summarize, my presentation, I would say that whenever you see a patient with CSCR, you usually, if it is an acute case, you usually wait for 3 months. But if it is a chronic case, or you can see that if it is a recurrent CSCR, you go ahead and start treatment. I primarily prefer to start with a subthreshold laser, where you can just go ahead and do a confluent laser. You can comfortably treat the subfoveal leak areas. You can easily repeat it. But if you feel that the microsecond laser is not working, or if it is not available, you can consider doing a half dose PDT. Just make sure that the patient is aware of the precautions after the treatment. And yes, we are rarely using focal continuous wave laser or threshold laser, because nowadays we all have access to subthreshold laser, so we want to do more safe laser treatment. So the focal laser is pretty much limited to the non-responder or the extrafoveal lesions. With this, I would like to acknowledge LV Prasad, where I worked for almost 7 years in India, and I would like to thank you all for your attention. Thanks a lot.
Thank you very much, Dr. Chhablani, for this really great presentation. I hope everyone enjoyed listening to it and learned something. Again, I'd like to ask everyone to submit your questions via the chat window. Just open the webinar application, open the chat window, and enter your question. I already see a few first questions. Dr. Chhablani, are you ready to take the first question?
Yes.
Cool. Then
Shoot.
let's go ahead with the first one. You said in one case that you can repeat the laser, and the question was, how often can you repeat the laser, and what is the, or what would you see as the minimal time interval between two laser sessions?
This is very important question, and that is where I really put microsecond laser as much higher over PDT, because we are always afraid in repeating the PDT, but with microsecond laser you can very comfortably repeat it. And I would usually wait for 2.5 months to understand what is the response, and if I am not satisfied, you are really very comfortable in repeating the microsecond laser. And the case which I showed, my first case, which clearly was a subfoveal leak, and the patient came back after 2 years with the fluid, and you know that the fluid is limited, you really don't need an FA. You can always just go ahead and do an extra laser with the 5% duty cycle, because we are pretty confident that it is not going to cause any structural damage. But you could not do this with PDT. And in fact, I can say that in PDT, whenever we do it, we are always afraid of associated RP atrophy, and which happens usually in the long term.
Okay, thank you. Thank you very much for this answer. I have one probably really difficult question, but I dare to ask that.
Mm-hmm.
Do you see CSCR as a cortisol-driven disease? Psychology, external or internal ways to elevate cortisol? Do you address some of these issues?
I wish we could answer this in this lifetime, but there are many studies where they have actually done 24-hour cortisol levels, and nobody can establish the direct relationship, because I know that there have been many more studies trying to correlate that, but we still don't have any answer to many of these questions. So, unfortunately, not.
Thank you, even if unfortunately not. But anyhow, we have more questions, so I'm happy
Mhm.
to ask you some more questions. One is directly referring to the way you plan. With a subthreshold laser, do you take any extra precautions when doing laser in papillomacular bundle?
That's again a very good indication. I always keep this subthreshold laser as an option for any of the papillomacular bundle leaks. I think the extra precaution is that you keep asking yourself, are you doing microsecond laser? Are you at that correct settings? Because we have had the episodes where, you know, uh, we missed out that, oh, we were not on the microsecond laser mode, we were on the continuous wave laser mode, and that can be really disastrous. So because when you're thresholding with microsecond laser, you are like really up high in the power, almost up to 800 900 millivolt, and if you are not on microsecond laser mode, this could be very harmful. So nothing specific for papillomacular bundle, but yes, it is the preferred choice doing a subthreshold. Uh, but make sure that you are at a very good, very low duty cycle. I would say 5% or is recommended.
Okay, thank you.
Mhm.
Another question also referring to the planning part is about the setting of the time duration. Is that in microseconds or in milliseconds?
It is in milliseconds. So,
Oh,
so the pulse duration will always be in millisecond, but that pulse duration for that duty cycle will eventually will have its own on off depending upon the duty cycle. So you are good. Whatever you see on the screen is the pulse duration. Go ahead and select that in milliseconds.
Yeah, so basically if you adjust the millisecond value for the envelope on the
Yes.
laser, but within that pulse,
Envelope there is an hour off.
you have
Yeah.
chopped pulses in microseconds, and
Yeah.
these depend on the duty cycle. Okay.
And I think this is important because, otherwise people get really worked up that, oh, what I'm doing, which duty cycle am I using? But this has been made to make it so simple for the clinician because we are used to using these term pulse duration. We just have to learn about the duty cycle. That's all. Rest remains the same, almost the same.
Thank you. Thank you
Mhm.
for that answer. I have one other question, which is not directly referring to the planning, but in sort of the management. It's about the different wavelengths. Do you feel that after 577 yellow laser, the green laser with 532 nanometer is going to be obsolete?
I really don't think. I really don't think that we would be able to like take away the continuous wave laser. But yes, it definitely has its role. But moving on with CSCR particularly, I really see that the subthreshold laser has a significant role, particularly in CSCR.
Okay, thank you. Another question also regarding all this management settings is what is the role of TTT in CSCR treatments?
That's a very interesting question, and unfortunately, I did not have experience with TTT, but some of my friends, colleague from India, they used to use that, and I have read their papers, and they show that it has a good success rate. But I do not have any experience using TTT for this.
Okay, regarding TDT, I have another question about the practical advantages of subthreshold over PDT.
Yeah,
What
sorry,
what
can you
are the
repeat the question?
practical what are the practical advantages of subthreshold laser on PDT?
Like I said, that one of the biggest benefit I particularly feel is that you are more confident in repeating this because you do not have to worry that oh this might lead to RP atrophy, which is a common fear with PDT. And particularly with Navilas, I like subthreshold laser because it gives you the report at end of the laser session, which tells you which exact areas you did the laser. So whenever you're repeating or you're repeating a fluorescein because of a recurrence or a persistent fluid, so you know that which area you treated and which area is now leaking. So do I really need to go back and treat that part? In addition to these, I would say that now PDT is not available in many countries. In United States, we do not have PDT in many states, but subthreshold laser is increasing, and I hope that eventually we would lead to moving everybody to subthreshold laser, which could be a much safer way of treating our patients.
Thank you. And we are approaching or growing forward in time, so I would like to ask one more question. And thereafter, I think we should go ahead with the multiple choice questions. Again, I will show you again how to use that. We would be happy if you participate in that survey by menti.com. But first, the last question. It's about how you do the treatment on the Navilas. Do you use the illumination light, the white light being on to see the color image, or do you use the infrared imaging mode during the treatment?
I would say that one of the biggest advantage, particularly with Navilas, I always found that you can actually do the laser, do the planning with the infrared because that is something really nice. If you really want to use the color photograph, just take the color photographs, do the planning, and then just import the plan to your live view, which makes it very simple for the patient and they remain really comfortable. So you have all the options, and infrared is more comfortable for the patient.
Are there particular situations that you would suggest switching the light on?
Not as such. I don't remember any specific indication. Nothing. Yeah, I don't think that I have anything specific for that. No.
Okay, thank you. That was the last question. So I'm happy to move on to a very exciting part for me because we are going to do this survey via menti.com. Again, you don't need to register. Nothing will be logged. Nothing will be tracked. It's just asking something. We will not save the results, nor can we find out who did which response. So let's see if we can answer the questions. Please open a smartphone browser on menti.com and enter the code 5125. I see you are faster than me. 0456. The first questions to come up. The question, by the way, is which treatment options do you have for persistent cases of CSCR in general? You can select multiple questions. I don't see how many people voted, but we have well above 100 participants. Let's see how many participate in the survey. The voting closes in about 20 seconds, so I will wait a few more seconds before Dr. Chhablani, you can present your response to that question. So as this is the first question, we wait a little longer, but I think the results are going to stabilize. And here we are, the voting is closed. Dr. Chhablani, can you give us your thoughts on that question?
All right. Yeah, very interesting. I think there was some trigger happy people clicking the oral steroids. But we do see that this distribution is something pretty common. The only thing which I think is the anti-VEGF, because I particularly do not advise anti-VEGF for CSCR unless it is associated with CNVM. But most often my choice is either to start with subthreshold, then go to PDT, and if I do not have subthreshold laser, then I will jump on to the PDT commonly. But if you have an extrafoveal leak, which you can do the laser, then again subthreshold is preferred because you just want to save the patient from any scotoma. And if you do not have subthreshold for extrafoveal, we can do a continuous wave conventional laser. Yeah.
Okay, thank you.
About the oral medication, I think I have used quite often, and I particularly like eplerenone. Though the Vichy trial did show limited usage, but I think it has its own weaknesses. But in the real life, we have seen sometimes a good response with eplerenone. However, we still have to learn a lot about this group of medication.
Thank you. So let's move to the next question. When do you advise PDT? Again, for those who want to participate, go to menti.com and enter the code you see on the top of the slides. The first votings are coming in. 15 seconds to go. I would wait for a little while further before closing the voting. And you already see it's a pretty clear answer from those who voted. Dr. Chhablani, would you like to comment?
Yeah, I agree with most of the people that, we usually offer PDT once the other treatment options fail. Um, the only thing which I really want us to understand is that the CSR is a disease where we should be really switching. This is what our international CSR group classification explains, that we really want to decide or define the CSR at presentation in a different manner, simple or complex, but rather actually waiting for the number of months mentioned by the patient. So I think, but for now, we really offer something less destructive, I should say. But if you really feel that the treatment is failing, then PDT is definitely a very good option. So yeah, I mean, I agree with most of the people.
Cool, thank you. Then let's go to the next question. Which is not a possible treatment pathway for CSCR? Again, you have the option to choose, you have the multiple selection option. Okay, we have one very fast, a very clear answer.
Yeah, these are just to make sure that people are active.
Yeah, are they still coming in bad? We close the voting now. And 96% are for intravitreal corticosteroids. Same with you?
Yeah, we
Wonderful.
usually avoid steroids. Yeah.
Then let's directly move to the next question. A patient presents with reduced vision for a few days. A neurosensory detachment is detectable and an ink blood leak can be seen subfoveally. How would you manage that? First voting is coming in from the fast voters, but we have 15 seconds left. But it seems to be a very, very clear answer here again. So the voting is closed. Again, most of the audience would say observation for 3 months. Is that the same for you?
I agree with most other people that if I see a subfoveal leak, I usually tend to observe. And as your patient is presenting with the reduced vision only for a few days, so it is still safer to wait. However, we can talk about that if the patient already had a CSR in the fellow eye, or the patient is one-eyed, their job profile is that they cannot wait, then I might just put them on an oral medication because if that works, that's great. But they are much safer. Eplerenone is very safe drug, so we can definitely offer them the eplerenone, but otherwise waiting is the preferred choice.
Fantastic. Then let's move to the next question. The same patient is returning 3 months later with persisting subretinal fluid. What is the next line in action, excuse me. First votes come in and it again looks like a very clear answer. Ten seconds left, almost no more movements in the bars before the voting closes. And here we are, Dr. Chhablani. What would be your response?
Definitely not further observation because we have already waited for 3 months. I think this is almost the same case of mine, my first case where we had the subfoveal leak, where we went ahead and did the subthreshold laser. So I am in favor of doing a subthreshold laser with making sure that I'm doing a 5% duty cycle and making sure that my thresholding is done correctly. Then I'm confident in doing the subthreshold laser. I know that if you do not have a subthreshold laser, then I might just do a PDT by going to half fluence or really 1/3 fluence, just to make sure that I don't leave the fluid there for a long time.
Thank you. So we have 2 questions remaining. The last but before is which parameter setting is possible for extrafoveal leaks? Again, you can select multiple options. Oh, we again wait. We see some questions coming up. Some varying responses. 4 seconds left. And we have closed the voting. Dr. Chhablani, could you give us your response to that?
I agree with these two top results, and because it is an extrafoveal leak, so you do not have, if you do not have subthreshold laser, go ahead and do a continuous wave laser. My usual settings are much lower than what is mentioned, 100 millisecond or 100 micron, because I like to start with the least power with the lesser duration. I just want to be as sublethal as possible. But if I have a subthreshold laser that's like the preferred choice for me, then I would comfortably go to 5% duty cycle, and rest of the parameters are as it mentioned. Yeah.
Okay, and we are now coming to our last question. Same question, just for subfoveal leaks. Which parameter setting do you believe is possible for subfoveal leaks? So we wait a little while, but I see the responses coming in. 7 seconds remaining. And the voting is closed. Again, Dr. Chhablani, your response?
I was glad to see the blue bar coming down, because I would be really worried to take my subcutaneous wave or conventional laser to the subfoveal area, because we all have seen the scar expands. So if I do not have a subthreshold laser, then I would really put them either on oral medication or on PDT, but I would never do a continuous wave laser. So given the options which are given here, the B or the pink bar is the one which suits me most. A 5% duty cycle with the subthreshold settings as we discussed. Yeah.
Thank you. So actually, we are at the end of our webinar. If you are interested in getting more information on navigated microsecond pulsing laser, we are happy to provide you with more details. Please contact us. The easiest is via our website. You can also register for a virtual demo on our online calendar. If you are interested in more clinical aspects and experiences, you can also visit our website in the expert library. There you find a lot of discussions. You find this webinar as well as recent webinars, as well as case presentations and other materials. With that, I'd like to thank the audience and also you, Dr. Chhablani, a lot for your availability today and your participation. One more comment, I think this was um, already starting to get deep into the subthreshold. I think you can even go deeper. So if someone is interested in further and deeper topics of subthreshold laser, please let us know via the feedback questionnaire that's coming up right after you left the webinar. We are happy to review your comments and to consider every suggestion that you have for us. Yeah, thank you for everyone. Thank you, Dr. Chhablani. I wish you a nice remaining evening, afternoon, or day, wherever you are based at the moment.
Thank you. Thank you so much, Ulrike. And it was really a fantastic webinar. I would say making it interactive actually kept everybody involved. This was really a good step forward. And I look forward to get more questions. And if anybody wants to discuss any case or have any questions for me, just feel free to get in touch with me. Thank you so much. It was a pleasure.
Thank you. Have a nice day. Bye-bye.
You too. Thank you.